Stiehl, and I'm a Senior Research Associate at the National Council of Juvenile and Family Court Judges, and I work with the Resource Center on Domestic Violence, Child Protection, and Custody. I'm really excited to introduce our webinar on information sharing today. Our guests have some really great work to tell you about. As many of you know, the families that we work with interact with multiple systems and agencies every day: the courts, child welfare agencies, domestic violence advocates, and the mental health services, to name just a few. To improve the lives of these families, agencies and systems must work together and learn to communicate frequently, openly, and effectively. Research demonstrates over and over that open communication is one of the driving forces of successful collaboration. When we talk about information sharing, we might be sharing information on a specific case, discussing agency roles and responsibilities, or sharing information about community resources. Today's webinar includes 3 examples of how domestic violence and child welfare agencies are working together to improve sharing of information and to help support positive outcomes for families. After all 3 of the presentations are finished, we'll have a period for question and answers. Please feel free to chat questions in the chat box, and we'll hold on to them until the end of the 3 presentations, and then we'll hope to get to as many as we can when we're concluded. So without further ado, I'm going to hand it over to our first presenter.
Hi, everyone. My name is Kelly Annelli. I'm the Director of Member Organization Services for the Connecticut Coalition Against Domestic Violence. And bear with me. Our presentation is not. Thank you. Thank you very much. Okay, again, thank you for joining us today. My name is Kelly Annelli, and I'm the Director of Member Organization Services for the Connecticut Coalition Against Domestic Violence. And we're just going to talk about some of the collaboration that we've had with our DCF program, our Department of Children and Families, and some of the steps we've had, challenges, and how we're moving forward. So just to give you an idea of Connecticut service stats, we serve about 40,000 people a year in our domestic violence program. A lot of our services come out of the court system, referrals to the court, referrals out of the court. We have about 30,000 crisis calls coming in a year. We do about 30,000 counseling and support services and house about 22,000 individuals and their children. And on average in Connecticut, sadly, we have about 12 to 16 intimate partner fatalities a year. Moving over to the DCF side, DCF receives through their care line about 105,000 calls a year, which is about 36,000 families. And most of them that are accepted, so 19% of the 31,000 that are accepted from just coming in from intake do have intimate partner violence identified. And DCF did do a study through the Injury Prevention Center showing that further down the road, the IPV was identified through those cases at 43%. So just to lay the platform is we know that there's a large co-occurrence of domestic violence and child abuse. And about 30 to 60% of children from homes where domestic abuse is present are also victims of abuse themselves. So we know that they do coincide and do go hand in hand more often than not. We know that domestic violence can cause serious psychological harm, social behavior, sleeplessness. We know the different symptoms of domestic violence as well. And that it constitutes the single greatest precursor for child maltreatment fatalities. So just some of the collaboration that we've done over the past couple of years with the Department of Children and Families. We received a grant from DCF that allowed us to implement into our programs the Kids Club and Moms Empowerment curriculum. This was a curriculum that ran for about 10 weeks, and it ran concurrently where children were brought to one room to do some sort of activity while being counseled as well, and then moms or dads were being also counseled. But every once in a while through the curriculum, it brought the parents together with their children to express different feelings that they've had. We've done the Safe Dates training, so that came through a grant with us with DCF as well. We trained over 500 people on Safe Dates, and that goes into the school systems. It's It's run through their life skills program or through their school counseling program. It goes along with a play, talks about being a bystander and witnessing teen dating violence, and it just is more of a preventative activity to put into middle schools and high school programs. We also have the Safe Sleep program, which we received some money from DCF to allow us to continue our work for safe sleep and try to educate parents of the possible harm of co-sleeping with their infants. This also allowed us to step forward in purchasing cribs for our shelter programs. Another program that we did was Through the Eyes of the Child, where we put out cameras into every shelter. Children were allowed to take pictures, non-identifying pictures of the shelter space, and then scrapbook what they liked and they didn't like about shelter. This actually allowed us to form a focus group with different entities from court, law enforcement, DCF, mental health services, and review the books and see how we can improve on different ways our referrals within the shelter and the work that we're doing with children across all capacity. We also have continuous cross-training of DCF caseworkers and investigators, and this actually developed through some work that we've done with Betsy McAllister-Gross and the Child Witness to Violence program out of Boston Medical Center. And what it was is we have a report which is available on our website. We have a report that discusses some of the struggles that we've had. It provided guidance, it gave us a process, and then some of the outcomes. And I'll discuss that a little bit later in this presentation. And then last, we've been having symposiums, so we're talking about, through the work that we did with Betsy, talking about the different needs that we have as two different entities and breaking down the silos. And we've brought in facilitators such as Casey Keene and Jill Davies from Greater Hartford Legal Aid here in Connecticut to collaborate and push forward our trainings and also really keep the floor open for these discussions and to be in a positive moving forward way. So just talking about, the mandated reporter. So here I'm not going to read it verbatim, but we do have, obviously we do have a mandated reporting policy in the state of Connecticut, and all domestic violence providers are mandated reporters. So that, of course, also goes hand in hand with the training that our advocates need as mandated reporters, but the continuous development that happens through DCF as an entity as well. Through the work that we also did with Betsy, we did develop a mandated reporting consideration. So how can we be more trauma-informed as domestic violence and DCF on making these reports when IPV is present? Just for a small background, in the state of Connecticut, in every domestic violence, in every DCF regional office, there is one or two IPV specialists. Those are intimate partner violence specialists, and they're our go-to person when we need to have the conversation. That is also the same on the end of DCF, where DCF is also supposed to refer some of their cases over to the IPV if it's present, to be a sounding board and make sure that we are working with this family as best possible. Some of the topics that we had through the mandating and reporting guidance sheet, and we developed a resource guide, was how do you make a decision to make a report? What's a children's reaction to domestic violence? What are their strengths? What are their vulnerabilities? You know, how old is a child? How does a child cope with stress? Just different things of getting some background instead of jumping into making the report. You know, what is really happening with this family? How do we make, after making this decision, is it safe? Is this going to be a safe step for this family? How are we going to support the protective parent? Talking with the parent about making a report. Let's discuss with the parent about making a report. Make them part of the report. And then the next steps into filing a report. And then some of the essential information so our advocates in the domestic violence world would better understand the essential information to provide to DCF, such as where is the location of the perpetrator? Is that a safety issue? Is that going to arise a safety issue? Are we putting this family in more harm? What are the natures of the threats made? Because then again, we know what the risk is. Does it raise the lethality of the situation? And what is the family support system? Are they going to have support after this mandated report is made? And how can we set this family up for success rather than failure? For some reason, I'm blank here, guys. Excuse me. I might have been excited and clicking a little bit too quickly. Bear with me. So relationship building, how did we build these relationships? First off, we had to look at what we did as DV advocates. What are all the hats we wear in our capacity as DV advocates? And that includes, from the minute the phone call or the individual walks in, all the way until we have a successful completion. What are some of the things that we do? Crisis intervention, intake, comprehensive needs assessments, individual and family service plan, just going through what are the basic needs. What is some of the information and referrals that we're going to have to make out for this family? And this is what we do when we do our cross-collaboration, is that we go through this. We needed to understand each other first. What is the role of the DV advocate? And what is the role of the DCF caseworker? And how does the verbiage, and I know in most arenas, when we're talking to one another outside of our arena, the verbiage that we're using is sometimes very different, but meaning the same thing, and breaking down those barriers of being able to speak each other's language. What are some of the psychoeducational groups that we have? What does our risk assessment look like? What does our case management look like? We really had to sit down and speak about this with one another. So with the IPV specialists on the DCF end, what are they providing when they take a case on? What are their main focus points when they get a case? So consultation, support, and coordination with DCF social worker. Trauma-informed strength-based approaches to child support. So what are they doing, and how a big focus is how does this align, and how do we have the most comprehensive approach for us to meet with both parties and get them to their next best place. Because in all honesty, there are many times where we have some systematic trauma, right? I mean, let's really call out the elephant in the room. And that's not always an easy thing to do, and it's not always an easy thing to say. But we can look at an advocate that may have had one bad case with DCF, one bad interaction, and next thing you know, that becomes pretty much the forefront of every case that they're going to have. That's what they're thinking of every time. And being able to discuss that was a very large part of this is okay, we see what happened here. How do we move forward from that? How do we change the way that we're working with one another? And just continuous ongoing collaboration with one another and keeping the systems and the lines open. So what are some of the complexities of the collaboration? So on our end, all of our records and services are confidential. When somebody comes in, we are not allowed to share without a release of information, which is usually the norm across the board. We cannot speak, and this is where, this was one of the challenges that we had, one of the struggles is that we may have someone saying, well, yes, I'm going to tell you X, Y, and Z, but I don't want you speaking with DCF. And also, honestly, people avoid coming into domestic violence shelters or calling domestic violence programs because they feel as though it's an automatic referral. And we know that can be very, very difficult for someone. And they don't know that it's going to be an automatic referral. We have to really talk to someone. And then we have a general statute here in Connecticut of privileged communication between a domestic violence or sexual assault counselor, which protects us, our advocates, and our clients with confidentiality. So that's our Connecticut general statute. Now, on the other side, DCF, they need all the information about the families, but of course their records are also confidential. And again, they do need the caregiver's consent, and it's required in order to disclose information. So disclosure, though, of information without a caregiver's consent is authorized in some cases, mandated. Now, on our end, that we cannot do unless there, of course, is a duty to warn, and that's if there's going to be some sort of lethal situation that's happening. And then exceptions may include, of course, children at risk, abuse and neglect, and risk of imminent danger, just the same as our end. Another, what's interesting is that when the case is opened with DCF, both parents have access to a child's file, which is the same for us, but the abuser obviously would never have access to another caregiver's file, the victim's file. So there's a lot of different barriers that we have to overcome just to exchange information and data. So what are some of the challenges? It's coming up on my end, but I'm not sure if anybody else can see it. Okay. So understanding the scope of service each entity is able to provide. So understanding one another. Like I said, there's always systematic trauma. A bad case could lead to somebody not reaching out again or not wanting to work with someone. So we have to understand each other. What are you able to do, and what are we able to do? How do we work best together? Understanding of the policies, and I've kind of went over that a little bit earlier, of understanding the policies of the different entities. But we really have to understand what the policies are. Great, I get it, but how do we work around it and with it for the best outcomes? And these are ongoing. I'm not going to be able to say, and this is how we solve it. What I'm really saying, and what I'm going to be telling you, is how we are moving forward, because this is a work in progress, and I feel as though it will be for quite some time as well. Understanding the roles of different DCF caseworkers. So within our domestic violence programs, we have adopted comprehensive advocacy where we are moving away from the child advocate and the adult advocate and the family violence victim advocate, where everybody is a domestic violence advocate, meaning that everyone is able to provide comprehensive services. Now, within the realm of Department of Children and Families, there's different roles. As I said, they have IPV specialists, but as of right now, there's only 13 in the state of Connecticut. So obviously, our victim advocates and our domestic violence advocates are going to be working with different caseworkers from DCF, so we needed to understand that as well. Investigators, social workers, IPV specialists, just some of the titles that they have. So clear policies on how DCF handles and determines what DV cases. And that was a challenge for us on the DV end, is that we would have an advocate with a parent call into the care line to be a mandated reporter and put in we call it a 136 to put in a case. And it would become substantiated, which means the case would be taken on by DCF and it would move forward from there. And on another time, the same advocate maybe will call in very close to the same case, and it would not be substantiated. And on our end, advocates were saying they were having a very difficult time understanding why one was and one wasn't. And there was no explanation at first. But because of this collaboration, these open forums, these symposiums, these cross-trainings, we were able to understand that when the case came in, DCF looks to see if there's something else going on. They may have had an open case in the past. They may have had, X, Y, and Z happened that the advocate has not been made aware of. And that was really a different idea for us, because we're thinking, like, if this is the same, then why isn't it being taken? So those open lines of communication really did help in furthering the understanding of the policies and the procedures of DCF when calling in a case. Also understanding the reunification and removal process. Somebody getting into housing, what are the steps? We do have moms and dads that come into shelter and they're waiting to get their children back. Maybe their children have been removed. We needed to better understand the case plan and the goals for that family. They would come in with goals saying that I need to do this for DCF to get my children back, and we had asked for a better understanding. So we've worked on establishing a better process of getting the information from DCF or from the parent to assist the family as a resource to the next steps that they need. Maybe it's counseling, maybe making that referral, so that instead of the two entities working in their silos, we're breaking it down and we're working as one to move this family forward and reunify a family with or a parent with their child. Of course, we know resources, large challenges, staff turnover within the Department of Children and Families, but also we're looking at staff turnover in our organizations. Many different resources. We know funding streams. We're a nonprofit. They're a state entity, so there's different funding streams. So it's difficult for you to continue the process. So that's been a challenge for us as staff turns over as IPV specialists. The 13 IPV specialists might take a different position. That changes the region, and it changes rebuilding those relationships. So we know relationship building is key when working together. And then, of course, the breakdown of our state. So, fortunately, Connecticut, we're the third smallest state. So, the breakdown is different. It's not a large state like Texas or California, where we're really, it'll take you days to get across, where you can drive from one corner of Connecticut to the other in about 2 hours. But the breakdown of the state really affects how we're doing work. And what I'll do is, actually, the next slide will show you. So here is what our 18 domestic violence program looked like. So in Connecticut, we have 18 domestic violence programs. They're broken down into different catchment areas. They cover different parts of the state. And you can see now when I go to the next slide that this is the way that DCF is broken down, and it's very different. So there's some overlapping. They have 5 regions, and the overlapping within the regions is very different as well, where one of our programs may be working within 2 regions, but also one region may be working with 2 or 3 programs. So just understanding how the different programs work. Obviously, different parts of Connecticut are rural, urban, suburban, so really trying to figure that out as well, and how we can better make it universal across the state, which is not always the easiest to do. So just talking about some continuous comprehensive approaches. And this actually was derived out of the work that, again, I'll go back to what we did with Betsy McAllister Groves. And this was not one-sided. This is what was also very important, is that it came from the top down, where our CEO and their director in DCF started the collaboration, and we brought it down further and further through the coalition, down through the IPV specialists, down through management, supervisory positions. Everyone had to be on board. And we developed some guidelines on, what do we want our outcomes to be? What do we want to do? We did focus groups and interviewed just domestic violence advocates. Then we also did focus groups and interviewed DCF case managers. What do you need on the ground? What do you need? Because we can't collaborate without direct service. You need to get your direct service involved. They're the most important. They're the ones on the ground doing the work. And so some of the comprehensive approaches that we came out with was increasing our cross-training opportunities between 2 systems, and that we've done. Like I've said, we've done conferences, symposiums. I'm actually the point person. I go out and train all of DCF's investigators. So when they do their training quarterly, I'm invited out to talk about our program so they have a better understanding of what we do, who we are, which has made an unbelievable difference over the past 2 years of just the phone call of picking up the phone and saying, hey, Kelly, I have this going on. Who's the contact person at your DV program that I can speak with? I mean, that's a step in the right direction of just being able to open those doors, pick up that phone, and make the call. Exploring the opportunity to fully understand each other's daily activities. So we've done case studies together of cases that worked and cases that didn't, because we can't always go off the successes as much as we'd like to. We do have to stop and think, wow, how could we have done this better? Our senior administrators are meeting, so the coalition is meeting with their senior administrators. We look back at our collaborative efforts. What were the outcomes of some of the work that we've done, the conferences, the symposiums, the focus groups? Can we do better? What does everybody need? And then we develop strategies to have case studies. So what we've developed throughout the state are somewhat like a learning community where everyone gets together, they're able to share ideas. It's I guess I'll say a judgment-free zone, a brave space where we can have these open conversations. And it's really tied everybody together in being able to openly discuss cases, move forward, and just learning about one another and breaking down those barriers, those silos. So that's really all I have to say about the collaboration. We keep moving forward. I'll be honest, we keep plugging along. We're doing. I think that we've come leaps and bounds. We've been working on this for quite some time, but really bringing in the outside facilitation and asking outside people, because when you're working within such a small state, sometimes it's difficult to see, the forest through the trees. And with us doing this, it's really moved forward, and I have to say that we've definitely been able to increase positive outcomes for our families. This is my contact information. If you have any questions or want to reach out, I'm more than happy to answer any questions you have. Share these documents that I spoke about with Betsy McAllister Groves. It is up on our website, but more than happy to share it with you as well, and any of the collaborative efforts that we have. So thank you so much for taking the time to let me speak about our collaboration in Connecticut, and I'll turn it over to the next presenter.
Thank you so much, Kelly. It sounds like there's a lot of evolving work in Connecticut that other states can learn from. Remember, if you're listening in and you have questions for Kelly or any of our presenters today, please stick them in the chat box, and we will make sure we get to them at the end of our 3 presentations today. Now I'm going to turn it over to our second presenters from Allegheny County, Pennsylvania. Andrea and Diane, if you're talking, you might still be muted.
It looks like their phone got disconnected. Can we give 1 second and we can try to get them reconnected?
Okay. Our apologies. We'll be right back on track in just a moment.
Can you hear us okay?
Yes, we can hear you now.
Oh, my deepest apologies. I'm sorry for the difficulties there. So to try to move us quickly along. So my name is Andrea Rudek, and my co-presenter today is Diane Allen. And what we will be presenting on is a local level regarding a partnership between a child welfare organization and a domestic violence program in our community. So my role is that I am a training department manager for Allegheny County Children, Youth, and Families, and we are the child welfare organization in the Pittsburgh, Pennsylvania area and surrounding suburbs around the city of Pittsburgh. We consist of a workforce of around 527 staff within our county jurisdiction, and that consists of about 328 caseworkers, 70 casework supervisors, and a myriad of different support staff that really wrap around our caseworkers to support case practice in our county here. Within Allegheny County, we have 5 regional offices throughout our county that handle all of our general protective service investigations and ongoing services to families. And then we have a centralized child protective service intake department that handles all of our investigations for suspected abuse and neglect in our particular county. So Pennsylvania consists of 67 different counties, and each county has a state license, the county-run child welfare organization. So the work we're going to talk about today is very specific just to our county within the state of Pennsylvania. So over the past couple of years, I have had the absolute pleasure of working with my colleague, my co-presenter here today with me, Diane Allen, and the organization with which she's employed, which is Women's Center and Shelter of Greater Pittsburgh, and have functioned as sort of a liaison on the child welfare side to our DV partner that's here with me today. So I'm going to turn it over to Diane to introduce herself briefly and then talk a little bit about the history of partnership between our two organizations.
Good afternoon. My name is Diane Allen. I have been with Women's Center and Shelter of Greater Pittsburgh for 18 years. Prior to the expansion project that launched in March of 2017, I was humbly assigned to carry the work of the IPV CWAS advocate in Allegheny County in serving the 5 offices as a IPV advocate. Upon our expansion work, we have been able to add 3 additional IPV specialists to the team. Historically, we were not aware of the level of work that would encumber one IPV advocate for 17 years. So Women's Center and Shelter and Allegheny County Office of Children, Youth, and Family Services was quite excited to set a precedent over the past few decades to embark upon the expansion of this work. And right now I'm going to move into a little bit of our history of partnership. In 1996, WCS developed and pilot tested a curriculum that was created by our former Director of Education, Janet Scott. And the curriculum was safety interventions with battered mothers and their abused children. This curriculum was to support the casework staff in Allegheny County in identifying, intervening, and to prepare a prevention method for families that are involved with OCYF and S within Allegheny County. This pilot project was graciously funded by the Department of Health and Human Services Administration in 1996. In 1997, this led to a 6-month grant from the Human Services Development Fund, which was received through Allegheny County to implement standards of protocols for caseworkers and transferring their PA risk assessment model for family violence into a standard practice of application utilizing WCS intervention and prevention services. In 1998, WCS received a full year of funding through the Human Services Development Fund and Shippensburg University to expand the project and continue training on protocols and procedures to address intimate partner violence and family violence for new and veteran OCYF child welfare workers, and to provide a full-time IPV advocate to collaborate in education and support of the caseworkers, in addition to providing domestic violence services to the victim, therefore the non-offending parent on the caseload. Since then, in 1998, Women's Center and Shelter has received 100% funding through a contract with Allegheny County Department of Human Services. This contract has been maintained status quo through 2017, and now we are moving into the expanded project under Children, Youth, and Family Services. And Andrea is going to share a little bit of information regarding the critical review of staff and system-level needs that led to the expansion.
So 2016 was a really important year for Allegheny County Children, Youth, and Families as it related to our work surrounding the intersection of intimate partner violence and child welfare. It was at that time that we as a system systematically recognized the need to deepen our work in relation to our families experiencing intimate partner violence, as well as our staff in their work with families experiencing some form of violence. So in large part, our realizations stem from the 2008 Act 33 amendment of our Pennsylvania Child Protective Services law, which is our regulatory body of work that really guides our child welfare services in Pennsylvania. So the amendment required state and local review of all child fatality and near fatalities that resulted from suspected abuse. Our reviews of these most complex cases over about a 5-year span leading up to 2016 consistently revealed and continues to reveal until this day a very high prevalence of intimate partner violence histories among the perpetrators of child fatalities and near fatalities, as well as among the non-offending parents in those cases as well. We found that at least about 50% of both the perpetrators and the non-offending parents reported some history of intimate partner violence as either a survivor or a offender in their histories. So based upon this trend analysis that we engaged in with our fatality review process, we knew that we needed to engage our casework staff in conversations to really understand what their experiences were in working with such families and in any family, even where there wasn't, of course, the occurrence of a fatality or near fatality, as well as to understand through our casework staff and their assessment experience what the experiences of their families look like in relation to intimate partner violence as well. So we engaged in those listening sessions with staff across at least 5 of our program offices and our intake department, where they were really able to help us understand what some of their challenges and support needs were as workers intervening and assessing families at that time, and where they recognized some of the support needs and challenges for their families as well, including the adult survivors, children, and the offenders of violence. And this also helped us understand where, through our long history of partnership with Women's Center and Shelter of Greater Pittsburgh and Diane Allen in particular, where that model of consultation support was working really well for our system and for our families, and where there were opportunities for strengthening it, as Diane had mentioned, with the expansion of the number of consultants available. So going back to 2016 again, at that same time, we began to take a universal education approach to talk with all families about the impact of violence. And to support this process, we included in one of our relatively newer family assessment tools a intimate partner violence module. And so the idea was is if we, through incorporation of this new module in our family assessment tool, if we were to put this matter on the radar of our staff, we believe that there was a better bet that we would do a better job of assessing this as a potential component for our families. And within the child welfare work, and I like to think this is not unique to Allegheny County, we know that allegations bring us to the front door of a family's home, but oftentimes it's not those allegations that warrant our continued involvement with the family. Sometimes it is, but sometimes it isn't. So we really needed to put IPV on the radar of our staff, knowing that oftentimes the allegations initially don't incorporate or include an element of family violence or intimate partner violence. So with that, obviously we know that just by adding a module within an assessment wasn't sufficient to equip staff with all they needed to do to engage families in safe ways and to have the conversations that they needed to have with families and to then support the service planning. And so ultimately, what we quickly realized is that we needed to engage in some additional system-level capacity building efforts for our workforce in this particular area. So what we see here is that we engaged in 2 capacity building efforts over the past 2 years, one of which involved a contract with one of our national leaders in the area of domestic violence, which is Futures Without Violence. We had contracted with Futures Without Violence through an RFP process where they were identified to work with our system stakeholders, both our internal staff and some external system partners, to do a few things. The first thing that Futures was able to provide to us was that we had pulled together a group of intimate partner violence practice leaders, as we called them, within our child welfare system. So these may have not been people that had the knowledge in this particular area, but folks that we believed we could invest in and help build their capacity, and that could further support, guide, and develop other workers in this particular area as well. Next, what Futures assisted us in doing was engaging community-based providers from both our domestic violence program communities as well as our battering intervention programs. The idea was is if we can engage them in conversations and bring them to the table with our child welfare practice leaders, that through cross-training of all of these stakeholders, we could really support improved relationship between our programs. And I think just as Kelly said, sometimes it was a matter of understanding language and how, what our jargon was and what their jargon was and where there's overlap and being able to support that relationship and that collaboration across our program areas. And lastly, through our contract with Futures, they had developed a intimate partner violence training curriculum for our child welfare workforce that was a supplement to what Women's Center and Shelter had previously provided, but that was really grounded in staff and stakeholder voice around our staff support needs in this particular area of working with families. So the second capacity building effort that we have engaged in is much of what Diane had talked about, which is entering into an expanded and new contract with our domestic violence partner, Women's Center and Shelter, to which we were able to go from having one specialist, which was Diane, for 527 staff, to expanding that to 3 additional full-time specialists for our workforce. And the idea was to take their support beyond the consultation role with families, which we know is important, but to also expand that consultant role to our agency workforce to build their capacity on an ongoing basis to safely engage our families and to support safety planning and service planning with them as well. So these specialists are now co-located in our 5 regional offices and in our intake department, to engage in that ongoing capacity building work. And Diane's going to share a little bit about that work as we are experiencing it today.
The contract expansion very much is still in its infancy stages, as most of you would imagine. As Andrea has stated, our 3 additional specialists are co-located in the 5 offices of Allegheny County Office of Children, Youth, and Families, and we are currently in the process of identifying a way to strategically serve the intake office, which is specifically different in the work that they do in being on-site, safety and risk, and receiving the referrals from our child abuse registry. We do know that in serving a dual role, the specialist serving a dual role, and being able to address the specific needs of the child welfare workers and their educational and consultation needs. And I don't want to leave out something that we are mindful of, and that is how this work can present vicarious trauma for the child welfare staff, and where my role as the primary IPV advocate lended itself to not only being in the position to train, educate, support, and consult, and to deliver the direct services to the non-offending parent who we identify as the survivor and victim, but to also be mindful and be conscientious that what is happening with the caseworker in regard to their caseloads related to IPV and family violence. Have they had their own history of intimate partner violence? Have they been childhood survivors of abuse or maltreatment? Is this affecting the work? How we need to build the trauma-informed foundation for that child welfare caseworker. This includes consultation to our system around areas such as policy, best practice, standards of practice, and protocols. When we're looking at the consultation and coaching of child welfare staff, being mindful of how many cases are coming into the unit, I would like to mention. How can we foster that relationship even greater between the office staff and the specialists? What are the needs of our specialists in growing more and understanding the work of child welfare? These consultations and coaching sessions, everyone, does come with its challenges. You know, what does work best for the building relationship with the workforce? Focusing on the relationship building efforts, unit by unit. Understandably, in each OCYF office in Allegheny County, you may have an average of 7 or 8 supervisors that may have 10 staff, on-ground staff. And we do know that each office, as well as each unit, can create its own culture. So supporting our IPV specialist team to be able to integrate their expertise into what is happening with each unit within each office is a very delicate and intricate process. You know, needing to do a check-in is very important. Informal conversations with supervisors at each office. That also includes how we rely heavily on the clinical managers. And I think Andrea will speak a little bit about the role of the clinical managers and the regional office directors as we move forward in this work. We like to engage them where they are, specifically in their perception of the work, how the work related to IPV is relative to what they see incoming with their unit. To help build relationships between the specialists and the workforce staff of child welfare, we can only have a grasp of the office and CYF practices, needs, and their opportunities of their challenges. Gaining trust. Gaining trust is not necessarily automatic from 2 ends. One, that child welfare staff will trust that where we support and lead them is effectively addressing their needs to engage their families regarding IPV, and looking from the direct service end, that how the specialists can be an integral part to gaining trust of the workforce staff. As Kelly had mentioned before, that there are barriers in establishing the foundation of trust between domestic violence programs and the workforce staff of Child Protective Services in Allegheny County, where often the specialists, the DV specialists, find themselves being the holder of very intimate information related to their experiences in IPV and how it has affected their children in regard to the occurrence of maltreatment, neglect, or abuse. Many referrals, we do know, historically have been focused on the work with the family experiencing the domestic violence. But in the expansion of the work, the goal is concentrated around how we can assist the workforce staff of Allegheny County Children, Youth, and Families in building their capacity and engaging their families and being able to carry that work and engage the work in a proper way that the specialist can then move beyond and being that direct service provider. Many referrals, can come with complexities attributed to mental health as well as drug and alcohol. And we do know in the domestic violence community where there is a co-occurrence of drug and alcohol addiction and the cycle of violence. And where we know trauma is present, that we may see experiences of mental health illnesses, such as post-traumatic stress disorder, anxiety disorders. How do we engage that? How do we not discriminate because these things are happening? Some of the continued challenges are IPV specialists need to be indoctrinated into the child welfare culture. This is paramount to our the expansion of this project moving forward, and Allegheny County continuing to set a precedent in the state of Pennsylvania. Identifying and understanding where staff are vulnerable, as I had referenced earlier, to the work with families experiencing IPV. IPV and domestic violence is safely guarded within families. When we think about a domestic violence structure, we're just not speaking of intimate partner violence, we're just not speaking of child maltreatment or neglect. There could be abuse against the elderly. Parents can be vulnerable to violence as well as sibling violence. Systems can be so overwhelmed with turnovers, regulations, high volume of cases, and they are not always bringing the experiences and education that physicians may dictate for this work. What good are you to me if you can't understand, if you don't understand where I am? Overcoming mindsets of an overburdened and overwhelmed staff. As we all know, the push and pull within child welfare systems. In some units, IPV has not reached a level of concern due to other factors being prevalent within certain demographics within our office. We do know as well 75% of women served have a very high ACE score. When we think about adverse childhood experiences and how relevant that is to what may be happening with an adult survivor, that is the non-offending parent, how we are able to connect the foundational work from domestic violence agencies to the work of the child welfare workforce continues to be a very intricate process. The work with the offending party, this is last but not least. Historically, we do know from a domestic violence agency's perspective, and even within child welfare, that the offending party has been ignored. This has been a historical perspective of how to deal with abusers. But what we do know that those that are the offending parties do come with their own histories of trauma. So Andrea is going to move on in the continuing to advance practices.
Right. So I think with all the challenges that Diane referenced, we know that there's a lot more work for us to do in this particular area. So just in summary, I mean, we will have entered into a new partnership with Futures Without Violence on a quick initiative, a quality improvement center on the intersection of domestic violence and child welfare, where they will be working with us as a program site for that quick grant on advancing an adult and child-centered approach in child welfare. And it's a capacity building and a research project as well. So hopefully there will be more information to come on that. And then lastly, we realized that because of all of the work going on in this particular area of intimate partner violence, and then also our work on the battering intervention side, that there's lots of pockets of conversations and people that are talking about this and that are approaching this from different angles, but the dots are not always connecting. So we realized that we needed to hire a program manager in the area of pulling all of these pieces together to really help us advance our system practice and the outcomes that we're seeing for our children, youth, and families. So thank you for your time. I know we've gone over, so we will turn it over to our Chapin Hall co-presenters here.
Thank you, Diane and Andrea. Our final presentation is a little bit different than the first two, and we're pretty excited about this. We have our presenters who will be talking about an innovative way to use that they're using technology to share information about community resources. So I'll turn it over to them right now. Thank you.
Thanks. Good afternoon. I'm excited to be here today to talk about how NowPow and Chapin Hall are working to connect vulnerable populations with services through some mobile technology that we're working on. I'm Mike Stiehl. I'm a senior policy analyst here at Chapin Hall, and I'm here today with Emma Roberts, the Director of Sales at NowPow, and we are going to discuss our partnership between our two organizations to address a need around service referral and how service arrays at agencies are being utilized by caseworkers and the children and families that need those services. So quickly, I'll cover what the challenge is, how Chapin Hall has experienced that challenge over time, why we thought partnering with NowPow made sense, Emma will talk some about NowPow and the solution we've come up with, and then we'll give you some an overview of some of the pilot work we've been doing with this particular piece of technology. So the challenge in many child welfare systems is one around case management, and the way we define case management is the process of assessing the needs of children and families, identifying community-based resources to meet those needs, and then connecting families with those resources. Typically, one of the big barriers to this process is having the critical piece of information you need at the point in time that you need it. And given that many staff are mobile, having access to resources on the move is becoming increasingly critical in order to make these connections. So I'll give you an example. We'll talk about David's family. David is a 9-year-old boy with an anxiety disorder, and his family is composed of his mom and dad and his 3 siblings ages 4, 6, and 7. A caseworker is sent out to help David's family identify resources in the community that could address some of his anxiety disorder issues. However, when that caseworker arrives, what they find is that David's family has been given an eviction notice. They were told about a week ago that their building has been foreclosed upon, and his parents are very much focused on what they're going to do for housing. They have about 2 weeks to make a decision, and right now they're looking at either doubling up with some friends who have children, maybe finding some relatives who'll be willing to do it, but they know they need to do something quick, or they may end up in a shelter or on the streets. And so now there's a new issue that the caseworker is confronted with that is overshadowing what David needs. And this particular caseworker is not an expert in affordable housing or housing issues, and knows that they now have to do a lot of additional research to help understand what's available in the community. And they also know that if this particular barrier isn't overcome, the window of opportunity to serve David will close. So typically in this situation, what we see is caseworkers will end up returning to their office and either consulting manuals or printed directories, maybe a Word document or Excel spreadsheet. They may do some research online, and then typically they'll end up packaging up all those materials and returning them to the family. That process can take days or weeks, and at that point, David's family may have already made a decision. And just to illustrate how challenging this is, you can't just Google search your way out of this problem. Oh, oops. Sorry. So this is what you get in Chicago in the 60647 zip code if you just look for rental assistance. You get about 40,000 results. In order for a caseworker to filter that, it would take forever. Google doesn't provide you with any ways to look at the types of payment these organizations would take, the populations they're willing to serve. It says nothing about whether or not they have existing contracts with the organization. So what we decided was that there was a need here to help caseworkers quickly understand the landscape of available services and filter them based on the needs of the people they were talking about or talking with, but most importantly, to do that in real time in a family's home location, which meant that this technology had to be mobile and it had to work on a phone, because most of our caseworkers these days have a mobile phone. So we wanted this information to be up to date, provide concise searches, relevant information, and on-the-spot accessibility. And many homemade directories or published directories don't do that, and as I said, Google also doesn't really have that functionality. What we at Chapin Hall have noticed is that this is part of a broader challenge. So Dr. Dana Weiner and I have been working in the Illinois Department of Children and Family Services for almost 15 years now, building service directories, web-based ways for staff to better connect with community-based services, and improve databases that allow the agency to understand where critical information is. And along the way, what we've learned is there's sort of 3 main barriers here. And one is that caseworkers need access to the full array of contracted community-based resources in a way that allows them to quickly find these services for their clients. It's not enough to just know what the Department of Children and Family Services is offering. You need to understand what other agencies are offering that your families and their children may qualify for. Families need to be able to get a list of services in a way that's convenient and comprehensive. It's not enough really to hand out printouts anymore. Email's pretty good, but a lot of people live and die on their phones. And so having the ability to text resources to clients in real time when you're sitting in the room with them seems like a critical function. And finally, most human services systems need to receive some kind of performance data to understand how their current service array is being used by clients and caseworkers. It was certainly the case in Illinois that once a referral was made, it was very hard to track that referral throughout its lifetime to understand, did the family actually follow up with the provider? Did they go to the provider? How many times did they go to the provider? Did the provider reach out to the family? All of that closed loop referral information was missing. And we feel that with this new application, we can provide organizations with not only a way to improve the utilization of their services, right? So to let nonprofit organizations make sure that they can get the families to them, or families being able to access services, but also agencies to be able to see those interactions for the first time and know of all of the contracted services they have, which ones are being used, how often, by whom, and for what services. So what we decided to do was team up with NowPow and build a new mobile application to do this work. And as Emma will talk about in her part of this presentation, there's sort of a long history between Chapin Hall and NowPow. NowPow was primarily focused on healthcare, and we were primarily focused on human services. And we were doing sort of similar work, but separately. And it became apparent about 2 years ago that we might be able to move child welfare and human services forward more quickly by working more directly together and utilizing all the things they had learned in the healthcare space about referring community-based resources with all the things that we had learned in Illinois around building the statewide provider database, which was a desktop web application meant to help caseworkers do referrals. So we had learned a lot about how to improve service referral in the child welfare space, but we lacked really the mobile technology or know-how to build an application that would meet many of the critical functions that we thought we would need to address. So we developed NowPow for child welfare, and it closes the loop on case management by providing comprehensive lists of community-based resources, a really improved family service referral connection, and targeted system performance analytics. So it's a mobile optimized web application. It just opens up in the browser on your phone. It has a really simple, friendly user interface that we've tested with, both in the healthcare space, and now we're testing it in the child welfare space. It has a comprehensive search navigation, which allows you to search both based on service types. So I'm looking for parenting programs, I'm looking for after-school programs, or by conditions. We've built custom condition algorithms so that you can put in things like anxiety disorders or depression or domestic violence, and it will actually suggest an array of services that meet those needs. It provides an instant connection between clients and services. You can text the results or the services to your clients. It's a very small text that sends them a link, so it doesn't eat up a lot of their data, and you can do it right in the room and see that they get it. It also allows you to translate those service referrals into, I think, 6 or 7 different languages on the fly. Emma can correct me in a little bit. It provides automated documentation. So one of the things we loved about NowPow was that in the healthcare space, it connected seamlessly with electronic medical records. And this gives us the opportunity in the child welfare space to help automate some of the documentation that consumes a lot of the time that caseworkers spend every day. It has crowdsourced service updates. One of the things we learned very early on in Illinois providing web-based service or service referral application was that it was only as good as the data was. So anytime a caseworker used our system and the data was out of date, they pretty much stopped using our system. So what's amazing about NowPow is nothing in their system is ever older than 6 months, meaning every 6 months somebody will check in on that data and make sure that it works. But what's really exciting about it is all through the system, there's a button that allows people to quickly update NowPow on what might have changed. So If it's a family interacting with a provider and the hours of service have changed, or the person that they're meeting with is different, they can quickly press a button, send a notice to NowPow and say, hey, this is different. Or the same thing with the nonprofit organization or the caseworker. All of those prompts become the first thing that anybody at NowPow does any day regarding the database. So they're making the critical changes first, and it helps keep the data much more up to date. Okay, we'll move on. So as I said, we've done some real-world testing on this. We piloted it in the winter, in January, February, and March of 2018, and we concluded our study in June. And we will have a academic paper out on the results, and we'll be doing some presentations on it. But the goal of this was to really understand how to train staff to use this application effectively, how well it really performs the critical task of connecting families and resources. So what does that actually look like? Could we improve the number of resources that families got? Could we help caseworkers understand the array that's available to them better? What steps need to happen in order to integrate this application into daily practice at an organization? And we got some user feedback. So what additional modifications need to be made both to the application but also to our training to make it more effective in a child welfare space? So now I'll turn it over to Emma, and she can talk more specifically about the details of the actual technology.
Hi everyone, hope you can hear me okay. NowPow is a play on knowledge is power. And I might need to get access to making the screen advance. Or Mike, maybe you could do it for me. Okay, perfect. All right, so I'm here to tell you a little bit more about how this app works. And really, this is the easiest way to think about it. We better connect organizations when they're making referrals. So the platform is multi-sided. We've got a user interface for referral senders and a separate interface for referral receivers. So there's lots of different ways that this can be applied. We do primarily work in the healthcare space, but as you can see here, there are so many different sectors that can benefit from this type of infrastructure. We did come out of a research project funded by the Centers for Medicaid and Medicare. So I won't go too much into it, but there were some substantial outcomes that were evaluated by a third-party research firm that showed that by receiving this high-quality, personalized community resource information at the point of care, patients and people had significantly fewer inpatient stays, unplanned readmissions, and ED visits. So it just goes to show that in the healthcare space providing this sort of systematic referrals can support people's health and wellness. And we're excited to be expanding beyond the healthcare space into child welfare and human services more broadly. We're in 7 states today. We're based in Chicago, and we do have a large presence in New York City and the Twin Cities as well. That's something that's interesting about our model, is that to build these high-quality community resource directories and keep them up to date, we do have this community-focused model. So we're not nationwide. We likely never will be, but if there is an organization like a Department of Health and Human Services, for example, that's interested in investing in this type of solution, we will come to that community, build that directory in partnership with existing ones like United Way 211 or others that are maintained by state or local governments. This slide really summarizes the functionality of what the app does. The first step is to identify the person's social needs. So, what is really a challenge for them? Maybe it's food insecurity or housing instability or job insecurity. Really just systematically figuring out what that might be. And that's often done by some sort of screening or assessment. The next step that NowPow really excels at is this concept of matching. So taking that assessment information, but also their demographics, like where they live, their gender, age, preferred language, and using all of those inputs to recommend specific programs and services that can best meet their needs. The next step is to share the information. So in the platform, you can easily text, email, or print the referral. And then the next step would be to track it with those social service agencies. So once that referral is sent, being able to have insight into the timeline of it being scheduled, communicating with that partner, and ultimately being able to understand that outcome. Did they make it to that behavioral health program or to the food pantry, whatever it might have been, understanding if that referral actually helped the family or individual. We support engagement along the way, so you can send text nudges and appointment reminders. And lastly, we have a comprehensive analytics platform so that you can see really what needs have been identified across the population, what referrals have been made, and what that referral success looks like. We do build these resource directories in collaboration with our partners, but also existing resource directory initiatives. So Mike did mention the statewide provider database here in Illinois. That's just one of many directories that we've incorporated into ours. So that's a big part of what we do. We would love to share a demo with anyone who's interested. This gives you a sense of what the platform looks like, and we're constantly adding new functionality to support specific interventions. So we do have social needs tracking and screenings, which are relatively new, as well as this community resource finder, which is a website for people to be able to look up resources on their own and self-refer. The platform is secure and HIPAA compliant. All data is encrypted both in transit and at rest. All activity is monitored and logged, and we have a really strict policy for user provisioning, so we know exactly who has access to what client data. Working in the healthcare space, this is really the #1 requirement of any sort of software solution, so similar policies and procedures would apply for the human services space. This is just a little bit more about our platform. So we do have a support portal and really comprehensive training to make sure that the users are able to use it in the way that's best for them. And just a little bit more about where we're hosted. We're in Microsoft Azure, and you have a lot of infrastructure in place for security. The reports really share some key insights into how the platform is supporting whatever intervention it might be. So just off the top, you can see, how many clients are being referred, reports tracking those closed-loop referral outcomes, what barriers might exist to accessing resources, and also some geospatial data, so understanding what the distribution of service providers looks like and where might some service gaps be. So how far are people traveling to access specific evidence-based programs, and what might be interesting for whether it's government agencies, foundations, or other stakeholders to invest in. Really having the demand for services known and captured can be really valuable for understanding what might be most important to invest in. So that is NowPow. I'll let Mike wrap things up here, and thank you all for listening. We would love to connect after this webinar.
Thanks, Emma. So what we're really excited about is the potential for impact of this tool in the child welfare space. We really think, and we've seen in our demo, that there are improved referral experiences for families. They get more of the services they need in a format that they can use them in. We see this as a human resources multiplier for child welfare by reducing the amount of paperwork and sort of low skills work that needs to be done. By automating it or auto-populating things, we increase the amount of time social workers and caseworkers can spend doing the high skills work that they want to do and that needs to be done. We think it's a real solution for out-of-date resource directories. We know that it will provide improved quality assurance mechanisms. We've seen it in the pilot already. It already quickly identified zip codes where there was lots of need and not a lot of services. It had some surprising findings about what caseworkers were really searching for versus what we thought they needed. It provides amazingly improved coordination and communications. We didn't really get into it, but almost at any point, there's a part of the app that allows you to actually track on a timeline how the referral is going. And at any point in that process, the agency, the nonprofit organization, or the family can communicate with each other to see why things aren't moving forward. And it really creates the capacity to evaluate impact. For the first time, by having analytic data on how service arrays are being used, we can build continuous quality improvement cycles that allow us to actually start customizing and improving what resources are being contracted for, where they're being contracted for, and in a way that happens in sort of real time that will really make our service arrays much more responsive to the needs of children and family. Thanks for listening to our presentation.
Great, thank you so much, Mike and Emma. Every time I hear about your work, it is more and more exciting to me, and I'm more impressed. So thank you for sharing that with us today. We're going to conclude today with some time for question and answers. Because of the number of viewers on the webinar, we have everyone muted, but if you have questions, you can type them into the chat box, or feel free to send me, Terry Deal, a private chat. I've collected just a couple questions through the course of our presentation today. So I want to start out first with a question for Kelly. Kelly, where can viewers find out more about the Kids Club and Moms Empowerment curriculum that you mentioned?
That's actually, it's available right online. Thank you for the question. It's available right online, right through Google. It's not something that was established through Connecticut. It's a national best practice trauma-informed support group layout. So if someone's interested, you can look it right up on there. If not, if you're not able to find it, I have my contact information. I'm more than happy. I have a couple extra copies here to send them out so someone can look through one of the packets if they'd like.
Great, thank you so much. And also, Kelly, can you please type your website into the chat box so that for folks that wanted to look up some things that you mentioned were on your website?
There you go.
Thank you so much. The next question I have is for Andrea. You mentioned the module that you added to the assessment for caseworkers, and folks are wondering if that's a module that you're able to share.
Oh, definitely. Would I just send that to you, Terry, perhaps, that could be disseminated out to the audience then?
Sure. Yeah,
Okay.
that would be fine. And just so the folks in watching know, this webinar will be recorded and on our Resource Center website, so I can also include any materials that our presenters want to share with us on that website so you can access it there.
And just to clarify too, I will send, I believe it would be the entire family assessment, the FAST tool, but within that it has the IPV module, and it sort of explains in there the instructions for how that module gets activated based on a first line of questioning. So.
Great, thank you so much. The next question I think is for both Kelly and Andrea and Diane. For people who are working in states and counties that don't have IPV specialists in their child welfare agency, could you speak a little bit to the type of skills or training that you might look for in someone that you would hire to be an IPV specialist?
Well, I actually don't hire the IPV specialists. This is Kelly. I don't hire the IPV specialists. They're housed under the Department of Children and Families, so they would do that hiring. Outside of their social work background and a minimal, from my understanding, a minimal understanding of domestic violence, they do all of their in-house training, and they invite us to do it as well. Like I stated, that I go out and do the training from their investigators. I do their orientation training. So they are allowing us, as you know, the expert in the state on domestic violence, to take part in training their advocates. So a lot of us are in this work due to a passion. Not, I wouldn't say that you wake up a small child when they're asked what they want to be when they grow up. It's, oh, I want to be a DV advocate. So the passion is really the guide, and then from there we train, and you really can't train around human activities. So it's more so just knowing the person and getting to ensure that they're going to work well with victims of domestic violence.
This is Andrea. I would only add, because we recently went through the process of adding additional intimate partner violence, and I know not all systems will have that kind of partnership, but I think for us in the search process, we Women's Center and Shelter and Allegheny County CWEF served as co-panelists in the interview process. And it was very important that we could look at folks that we, from both system perspectives, can see being successful within each of those systems and service sectors, and also be patient and open to the process of growing and learning about each of those systems as well. I think, if anything, there were some core competencies that we tried to focus on in the candidates to really consider whether or not, and I think that speaks to what Kelly had mentioned, sometimes it's not about what they bring, but what they're open, I think, to in terms of that learning process.
Yes.
Thank you so much. I see that there's a couple attendees who are typing in the chat box. So while they are finishing up their questions, here we have a question, or a comment. So you guys can read that comment there from one of our attendees.
So interestingly enough, this is Kelly, and thank you for the comment, Anna. Interestingly enough, we have a shift, and it will take quite some time in Connecticut, that we're moving to like the family justice concept, where not just DCF is housed within the domestic violence program, but also there are times when law enforcement has an office there, and they're utilizing that office, as well as attorneys and all different practitioners are coming in, and they are given office space within our Family Justice Center. And the model itself has worked wonderfully, where victims are coming in and they're seeing that these individuals that they once may have been fearful of are actually a partner, not the enemy, and that does move the work forward, I have to say.
And my last question that I have here is for Emma and Mike. There's a question if NowPow provides assistance to agencies who want to learn how to use the data that it's collected.
So go ahead, Emma.
Oh yeah. Yes, so absolutely. That's a kind of a big part of implementing NowPow, is really upfront understanding what data will be collected as a result of using the platform, and how that data can be used to evaluate, the work, what referrals are being made, and who the referral partners are, what the success is looking like, where might those barriers be. So really understanding what the reports are saying and how that can be used to take some sort of action.
Yeah, and Chapin Hall has a long history now of providing a lot of implementation support to different organizations. And what was exciting about the pilot was having a partner like NowPow, as we learned that some of the analytics that came standard with it didn't quite meet the needs of the organization. We were able to work with them to very, very quickly make modifications to a data pull or a report so that it matched the processes of the organization we were dealing with. And going forward, I think both of our organizations understand that providing support beyond just training beyond training on how to use the app, but how to use what the app tells you, is a really critical space to be in, and provides a big benefit to our partners.
Thank you, Emma and Mike. So that's it for the questions that I have right now. So I think that will conclude our webinar for today. I want to thank you so much to our presenters, Kelly and Andrea, Diane, Mike, and Emma. Really wonderful work that you're doing, and thank you for sharing it with us. Again, thanks to the attendees for coming in. Any questions that you have, you feel free to forward them to the Resource Center, and you can see our website there on the screen, rcdvcpc.org, and this webinar as well as related resources will be posted there in the next few days. So